Dr. Rob Beattie. I'm an orthopedic surgeon at Northwestern Medical Center. I specialize in knee, shoulder, and hip surgery. So you've been diagnosed with a torn anterior cruciate ligament. What does that mean, and what should you do about it? I'd like to take a few minutes of your time to discuss the anterior cruciate ligament, its anatomy, mechanism of injury, diagnosis, treatment options, surgical management, both from a historical perspective and current surgical management, as well as potential risks and complications, post-operative course, and expectation for outcome. First, the anterior cruciate ligament is a very important stabilizer of the knee joint. It is a strong band or cord of tissue that runs obliquely through the center of the joint, attaching the femur, or the thigh bone, to the tibia, which is the shin bone. It is the primary restraint to anterior tibial translation. That is, it prevents the shin bone from sliding forward under the thigh bone, particularly in extension, more so than in flexion. It's particularly important for pivotal sports or activities that require sudden changes in direction, cutting, turning, twisting. Many people are able to live with their torn ACL for simple activities of daily living, but sense instability when participating in pivotal sports. Others may have instability even with simple activities of daily living. There are a number of potential mechanisms of injury. The anterior cruciate ligament can be torn during contact sports, but interestingly, even more commonly, it can be torn without contact. In fact, the most common mechanism of injury is a twisting, turning, or pivoting or cutting action, as is frequently seen in sports such as soccer, basketball, football, or lacrosse. It may occur coming down and landing awkwardly from a jump, such as in basketball or volleyball. And in skiing, that long lever arm of the ski, combined with the twisting and angulation, makes skiing another common mechanism of injury. The patient presents with a story of injury, and often they may feel or hear a pop or snap with pain, swelling, and decreased ability to weight bear. The extent of weight bearing varies from those that are unable to weight bear at all to those that are actually able to walk or limp off the field, or even to try to ski down the rest of the mountain. Thus, the initial disability is quite variable. Most patients instinctively know at the time of the injury that this is a serious event, whereas occasionally they are surprised to find out that it is such a significant injury. Initially, the diagnosis may be missed. Pain, swelling, and guarding may impede the identification of the ACL injury on initial exam. Initial x-rays are often negative except for swelling, although occasionally there can be a small bone fragment that's avulsed and identified on x-ray. Initial treatment in the emergency room or the initial contact with the primary care provider usually consists of crutches, ice, elevation, potentially a brace, along with a referral to orthopedics. By the time you actually see the orthopedic surgeon, you may be past that initial pain, swelling, and guarding, such that the physical exam, in experienced hands, can allow identification of the ACL injury. You will be referred for initial physical therapy and usually an MRI. The MRI is in part to confirm the ACL injury, but primarily to assess associated injuries such as bone bruising, meniscal tears, collateral ligament injury, injury to secondary restraints. So that at your follow-up with the orthopedic surgeon, armed with the history, physical exam, x-ray, and MRI, we're able to confirm the torn ACL and the associated injuries. You will then be faced with a decision regarding treatment. Conceptually, there are always three treatment options for the torn ACL: avoidance of pivotal activity, bracing for pivotal activity, and surgery. We think of that as the ABCs: A, avoid; B, brace, and the French for surgery actually is chirurgie, starts with a C. So those are the ABCs of treatment options. But regardless of the treatment option, it is important to avoid repetitive giving out episodes, as this does further damage to the joint. Re-injuries can damage the articular surface cartilage, can cause tears of the meniscus, and can stretch out the secondary restraints. The results of surgical stabilization of the knee are not as good in patients that have had multiple re-injuries. So option 1, live with it, avoid pivotal activity. This is a reasonable option for the older patient that does not plan to participate in any pivotal activity. However, for young active athletes, this is a poor choice because of the tendency for additional giving out episodes. It's unreasonable and in fact probably even unrealistic to expect a young athlete to completely avoid pivotal sports in order to prevent those re-injuries. Some patients even have giving out episodes with simple activities of daily living. This is a strong indication for surgical stabilization with ACL reconstruction. The second option, to brace for sports or pivotal activity, has some limitations. Many young athletes have difficulty complying with brace use because they don't always have the brace with them and often choose to chance it and engage in a pickup sport, leading to re-injury and further damage to the knee. For example, if a patient was at a friend's and they decided to throw the frisbee around, next thing you know, they're playing a little ultimate frisbee, and the patient doesn't have his brace, ends up re-injuring the knee, causing further damage and jeopardizing long-term outcome. The other problem with bracing is that at least 20 to 25% of patients will have instability even using the brace. The use of the brace seems to be more applicable to the older patient that has no sense of instability with simple activities of daily living and is not participating in frequent pivotal sports, but occasionally engages and can plan for it. A good example would be the once or twice a week tennis player that is not otherwise participating in pivotal activity. The ultimate goal is to avoid those secondary injuries where the knee gives out due to the lack of a functioning ACL. These giving out episodes lead to higher shear on the articular surface cartilage and stretching out of those secondary restraints and a gradual and inexorable deterioration in the knee joint. The most common treatment for the torn ACL is an anterior cruciate ligament reconstruction. Surgery is generally avoided in the early phase right after injury because studies have shown that there is a greater incidence of stiffness if you add insult to injury by early surgery. A brief delay of 4 to 6 weeks is typically recommended to allow resolution of most of the pain and swelling and to regain range of motion prior to proceeding with the ACL reconstruction. This delay helps to decrease the likelihood of knee stiffness post-operatively. Historically, many patients that have had a torn anterior cruciate ligament went undiagnosed and they had to live with a trick knee. Then there was a period of time when surgeons attempted to perform primary repair of the torn ACL. Unfortunately, there was a significantly high failure rate for primary repair, and so surgeons sought a more successful approach. Rather than trying to sew the original ligament, which tends to be more like sewing mop ends, sports doctors changed to the use of an ACL reconstruction, where we build a new ligament using an autograft of your own tissue. Over the last several decades, there has been a gradual and continuous evolution of the reconstruction techniques. Early ACL reconstruction involved harvesting the IT band, which is down the side of the thigh, and this could require a 12-inch long incision up the side of the thigh and a 5 or 6-inch incision on the front of the knee to open the joint and build a new ligament. Post-operatively, they were placed in a cast for 8 weeks or more, and there were significant consequences to both the surgical technique and the post-operative immobilization. Although there were improved outcomes for stability, there was often loss of knee range of motion and post-traumatic arthritis. There has been an evolution not only in technique, but of the various autografts that have been used as well. The most common autografts include hamstring tendon and patellar tendon autografts. There's also been a trend toward increased use of allograft, which is tissue taken from a deceased patient or cadaver. Studies, however, have shown that patients under the age of 20 have a higher failure rate with allograft compared to autograft. Interestingly, after the age of 25, The results for both autograft and allograft are comparable for stability. So for patients under the age of 20 to 25, I recommend use of autograft after the age of 25 because the results are comparable and there is some degree of decreased morbidity with the use of allograft. I do give patients their choice. The benefit of allograft is that you do not have to rob Peter to pay Paul. There is no tendon harvest. It does involve a smaller incision. There's less numbness. It's more cosmetic, and there tends to be less post-operative pain. However, it should be noted that it's not any faster in healing. If anything, allograft incorporation is slower than autograft incorporation into bone. After ACL reconstruction with allograft, you should plan to be off aggressive pivotal activity for at least 1 year. For autograft, it is about 9 to 12 months. As I mentioned, the most commonly used autografts are hamstring tendon and patellar tendon. There are pros and cons to each. In fact, I used to use primarily a bone tendon patellar tendon autograft, which is a very good graft. However, it did have increased morbidity from the harvest. I've basically transitioned primarily to using a hamstring tendon autograft. This is associated with lower graft site harvest morbidity, and with current techniques, there are comparable outcomes for stability. We used to use 2 hamstring tendons, both the semitendinosus and gracilis tendons, doubled over to create a 4-bundle autograft. We're now using just the semitendinosus, but quadrupling it, and only taking the gracilis if the 4-bundle graft is of insufficient size. Our goal is to have a graft that's at least 8 millimeters in diameter. We used to use full tunnels right through the bone and out through the cortex. We now use blind sockets and preserve the cortical bone. We used to use cancellous screw fixation and now use rigid cortical suspensory fixation. The current technique also allows retensioning of the graft once it's in position and after we cycle the knee through range of motion so that we can maximize the graft tension at time 0. Our current technique then, that we've been using over the last several years, involves the use of a hamstring tendon autograft, quadrupled semitendinosus plus or minus gracilis if needed, done with an all-inside technique with bone sockets, cortical button fixation, and the ability to center the graft between the femur and the tibia, and the ability to retension the graft after cycling the knee through range of motion. We've been very pleased with the outcome in terms of achieving a stable knee, good range of motion, and minimizing complications using this technique. However, whenever we embark on a surgical procedure, there are always potential risks and complications. We make every effort to minimize the risk and to avoid complications, but nonetheless, they may occur. For example, the risk of infection is about 1%. We're diligent in trying to avoid this serious complication. There will be scar formation. There are 4 arthroscopy portals and the 1.5-inch incision on the medial aspect of the upper tibia, which is just below the knee on the inner side. There can be wound healing delay, which occurs in about 3 to 5%. The majority of wounds are healed by 7 to 10 days. Anything more than 2 weeks would be considered delay. There's always potential for injury to nerve or vessel. There's a small branch of the saphenous nerve which runs across the front of the knee, and this can cause numbness on the outer aspect of the knee and leg, just below the knee. This occurs almost 100% of the time when we were using patellar tendon graft. It still occurs about 1/3 of the time even with hamstring tendon graft. Bleeding and bruising always occur. This is usually an ounce or 2 of blood loss. It will not require transfusion, but the bruising can track down the inner aspect of the leg, and sometimes you can even develop a dark bruised patch on the inner aspect of the heel. DVT is a deep vein thrombosis. This is a clot that can form in one of the deep veins of the leg. This is not common in young, active athletes, but nonetheless, it could occur, and we try to minimize the risk of DVT by having you use a baby aspirin daily until you are completely out of the brace at 6 weeks. CRPS is chronic regional pain syndrome. This is an abnormal pain response, pain out of proportion with the pain we normally expect to see post-operatively. Everyone has pain, swelling, and stiffness, but with CRPS, it is significantly worse, and it can slow down the rehab and have a negative impact on the quality of outcome. Fortunately, it only occurs 1% of the time. All patients have the post-operative pain, swelling, and stiffness, and initially have decreased range of motion, strength, and function. This requires time and physical therapy and dedication to the rehabilitation of the knee over the first 6 to 9 months. Failure of the ACL reconstruction can occur in 5 to 10%. This implies that the surgical procedure failed to provide stability to the joint. At follow-up, there may be residual anterior laxity detected on physical exam. There is also the potential for a successful ACL reconstruction with a stable knee to go on to re-tear. This also occurs in 5 to 10% of ACL reconstruction patients. The re-tear rate is higher in patients under the age of 20. This can lead to the need for further surgery, so that either a failed ACL reconstruction or a re-tear may necessitate revision ACL reconstruction. Anyone that has had a torn anterior cruciate ligament is at increased risk for a torn meniscus or meniscal cartilage. This may need to be addressed, most commonly with meniscal repair, possibly with partial meniscectomy, which is a trimming of the torn part of the meniscus. Long-term, there is the potential to develop post-traumatic osteoarthritis, which is wear and tear arthritis, a deterioration in the joint, which occurs secondary to ACL injury. Long-term follow-up studies suggest that even with ACL reconstruction, we're not able to prevent the development of post-traumatic osteoarthritis. It appears that the osteoarthritis cascade has been initiated by the ACL injury, with the bone bruising, the associated articular surface cartilage damage, and the potential associated meniscal damage, all of which predispose to the development of post-traumatic arthritis. Statistically, every patient that has a torn ACL is at increased risk for a re-tear of their ACL, both on the injured side, but equally increased risk on the non-injured side. So that we're very aware of this, and this is part of the preventative measures we take during the rehabilitation process. Now, post-operatively, you will be in a rehabilitation brace. Initially, this brace is locked in full extension to encourage regaining full extension. That terminal extension is important for the subsequent rehabilitation of the knee. The brace is removable to work on knee range of motion exercise, but is worn for ambulation and is worn for sleep for the first couple of weeks as well. Use for ambulation is for the first 6 weeks. Subsequently, once the full range of motion has been achieved after the first couple of weeks, the brace is unlocked in physical therapy to afford a more natural gait pattern. A cryo cuff will be used. This is a device that is a cooling device and is simpler to use than ice. It's helpful for pain and swelling control, and you'll be educated on the use of the cryo cuff. Initially, this will be used continuously, and then as pain and swelling improve, the frequency of use of the cryo cuff will gradually decrease. However, you will find it's beneficial for the first few months on a gradually decreasing basis. You will have crutches. Initially, you'll find it's more comfortable to be partial weight bearing. As pain and swelling improve, you will be gradually increased to full weight bearing. Patients are typically on crutches for the first few weeks. Even after that, they may use crutches when they're up on it for longer periods of time in order to decrease or minimize pain and swelling. As far as ambulation goes, it's preferable to be up for frequent short periods of time rather than one long period. In order to ambulate, you disconnect the cryo cuff and you're up walking with the brace and crutches frequently but briefly, and then rest, ice, and elevate in the early phase. Physical therapy will be started immediately after surgery, within the first 1 to 3 days. We have an entire 6 to 9 month rehabilitation program designed to maximize your recovery. The initial goal will be to decrease pain and swelling, then improve range of motion, then improve strength, power, and endurance, ultimately to pursue functional rehab and sport-specific rehabilitation, and finally return to sport testing. Patients often ask, when can I return to sport? Unfortunately, we cannot speed up the biology of healing. The anterior cruciate ligament graft has to heal to the bone. It then becomes revascularized, and during this revascularization process, the graft actually weakens. There is then a remodeling process. Studies have shown that the initial tendon that we use for the reconstruction undergoes a process called ligamentization. This means that the tendon actually gets remodeled into a ligament. This process continues out to 18 months and even up to 2 years. As we rehabilitate the knee, there is a gradual increase in stress on the ligament, which stimulates the remodeling and maturation and strengthening of the graft. Although some patients feel ready to go as early as 5 or 6 months, post-operatively, the graft is continuing to mature and strengthen. Our goal is to plan for safe return to sport at 9 to 12 months, provided we have achieved resolution of pain and swelling, regained full range of motion, restoration of strength to within 90% of the normal side, and appropriate quadriceps hamstring strength ratios. Physical therapy testing to be sure that there is sufficient recovery prior to return to sport. And return to sport is really not on a timeline as much as it is a combination of timeline and success in rehabilitation and return to sport testing. As far as sports bracing is concerned, the highest incidence of re-injury occurs in the first year of return to sport, when the graft is remodeling and the maturation process continues. Once you have passed return to sport testing through physical therapy, you will be fitted with an anterior cruciate ligament derotation brace for use during that first year of return to sport. Thereafter, the brace can be discontinued. Return to school is typically after 1.5 to 2 weeks, starting off half days for a week or two and then transitioning to full days as your recovery progresses. As far as return to work is concerned, it's very much dependent upon the nature of the job. This can vary from 1 to 3 months. Now, this has just been an overview of the anterior cruciate ligament. I hope this has helped to educate you on the importance of the ACL and what to expect. I'm sure that this has generated additional questions, and I'm very happy to answer them for you. Thank you.